Okay, we're going to get started with the hematological system with a focus on the red blood cells and the clotting system. All body system, tissue, organs require oxygen and nutrients to survive. So the delivery of that is via the hematological system via our blood. Red blood cells provide oxygen, remove carbon dioxide, and then carry nutrients, proteins, and ions to sites for proper functioning of our body. They also discard waste from the tissues and carry our antibodies and able to fight infection. The other thing that it does is regulates body temperature and also acid base balance. Your blood, we have our plasma component, we have white blood cells, platelets, red blood cells. The plasma portion is about 50 to 55%. The red blood cells are about 45%, white blood cells less than 1%, and platelets are less than 1%. Concentration may vary based on metabolic demand, the patient's diet, hormones, and vitamins, but overall, these should be the classifying numbers with that. When we have plasma or serum, just remember the difference between serum and plasma is that serum has been allowed to clot in the laboratory and they remove fibrinogen and other clotting factors that may interfere with some diagnostic tests. So it's allowed to clot. When we talk about the major proteins, we are talking about albumin and then the gamma globulins. And those globulins are the ones that we get from our adaptive immunity. All right, when we're talking about the hematopoietic stem cells, we are talking about this pathway again. So this is a good high yield slide for you to kind of understand where the lineages are coming from. Over here, we do have that adaptive immunity, and we have the lymphoid progenitor line, natural killer cells. We also talked about the white blood cells last when we were talking about immunity. Remember that you have two types of bone marrow. You have red bone marrow and yellow bone marrow. The hematopoietic stem cells reside in the red bone marrow. The yellow bone marrow is fatty and basically inactive. Our body produces about 100 billion cells per day, so it's quite massive about how much turnover we have. When we're talking about anemia and things like that, then we'll actually hone in on the erythrocytes. So these hematopoietic stem cells are undifferentiated, meaning they will have some type of growth factor that comes in here and stimulates which lineage we need to differentiate into. For hematopoietic stem cells, it's either going to be red blood cells, white blood cells, platelets, and everything that is included underneath those differentiated lines, which is why this is a good schematic to understand. After we get those growth factors in, there's many of them. You don't need to focus there. Depending on what's going on in the body, we will have certain ones that are stimulated for what we need to do. So it is all related to what's needed. We will get a growth factor for that, and then we will differentiate. So this is a multipotential, meaning it has multiple lines that come off of it and stimulated by certain growth factors. Then we come down in here. So now we're going to still be in the myeloid progenitor line, but we are going to be focusing on erythrocytes and megakaryocytes tonight. First up, red blood cells. The process of getting the red blood cells from the hematopoietic stem cells is erythropoiesis. So that's a regulated process of red blood cell production through a series of steps. It occurs in the bone marrow. There are certain bones that this occurs in most, and it's actually vertebrae and pelvis. About 50% of our blood cells come from these two areas. The other ones are the proximal ends of the long bones, so the closest to the body, the mandible, cranium, and sternum. Comes from the Greek word erythro and piesis, meaning to make red blood cells. The normal amount of red blood cells is 2.5 million per second. When we have states such as anemia, it goes up to around 17 million. The way that red blood cell erythropoiesis is stimulated is by decreased tissue oxygenation, such as with anemia or pulmonary disease. We talked about the availability of the oxygen getting across when we have pulmonary disease. That would also lead to tissue oxygenation issues. And then high altitude living, such out in Colorado, in those areas. The main issue is detected by the kidneys and the peritubular cells, and they will then secrete erythropoietin. We also have a little bit of erythropoietin that comes out of the liver. We also need nutritional requirements to be able to form the red blood cells, and this includes all of these listed here, and then iron, obviously, for hemoglobin synthesis. All right, so over here we have the kidney. And I'm just going to put a little bit of the liver up here. but these are going to be the main areas that we are going to get erythropoietin from, and it is induced by hypoxia. Two compensatory mechanisms that the body does for hypoxia is first, we're going to increase ventilation to try and get more oxygen into the system, and then if we have decreased oxygen carrying capacity, which is anemia, then we would try to boost up our red blood cells. We have carotid body artery chemoreceptors, we have aortic arch, so we have many mechanisms by which we are going to detect low O2. So then hypoxia is going to stimulate erythropoietin to be sent down to the hematopoietic stem cell, and then that is going to be the differentiating factor. So we are now going to come in here and have these receptors be bound by EPO, and that's going to start the process. Here is called a burst forming unit, erythrocyte. This is also considered a proerythro. You can see it has a nucleus, it has receptors, it's also going to have other organelles in here and endoplasmic reticulum. We're going to be able to make proteins. This does have DNA. And another thing to consider is as we move down this line, the nucleus, DNA and RNA, and ultimately protein synthesis. And that protein synthesis is actually going to be the hemoglobin. So nucleus is big. We're still doing most of the things that a nucleus will do. And then we start condensing, we start getting smaller, and we start to get into the process of looking more like an erythrocyte. This has more of a blue-red form color to it when we look at it under the microscope. CFU stands for colony forming unit erythroblast. And this would still be kind of, this is actually called a basophilic erythroblast. So as you can see, these are both EPO dependent, so important for this process. Now over here you see iron. The other things that would be of great importance here are going to cause problems would be B12 and folate, and they are involved in this DNA. They're deep DNA precursors, and they're going to potentially alter the way that the red blood cell made. So now we're iron dependent. Iron comes in, and we start really taking on the hemoglobin process and getting the hemoglobin molecules formed. As you can see, the nucleus condenses greatly. It is still present, but now we're going to get to this erythroblast state, or a polychromatic erythroblast. So that's the main process here, is we are getting hemoglobin. As the hemoglobin gets full, then we basically push out the nucleus, mitochondria, pretty much all the organelles other than a few. Some organelles do remain, but the nucleus, mitochondria, endoplasmic reticulum, they are all gone. So this is the nucleus, mitochondria, ER, and many other more organelles. What remains in these blood cells are actually cytoplasmic enzymes, and they are capable of glycolysis. So the red blood cell still needs to be able to facilitate 120 days, right? 100 to 120 days in the circulation, moving in and out of microcirculation all the time. So we still need to have a little bit of energy, which is like glycolysis. So it's anaerobic glucose metabolism, and then also a small amount of ATP for its ability to move through the microcirculation and do what it needs to do. As the cells get older and senescent, around 100 to 120 days, then we lose that pliability, we lose the ability to produce the ATP, and they actually start getting stiff and start breaking down, and that's when we get into cell senescence with the spleen and the macrophages, and we're going to talk about that in a few minutes, and getting rid of the old blood cells. So we are still in the bone marrow, and that's why this is a nice little schematic. We are all doing that in the bone marrow. Now we're getting into this immature reticulocyte. So this stays in the bone marrow for about 1 day as an immature reticulocyte. We are all full of hemoglobin, and there are about 300 hemoglobin molecules per red blood cell, and each hemoglobin molecule can bind for oxygen. So then it's released in the circulation. So now we're into the blood system as a mature reticulocyte, but it is still a reticulocyte. It lasts here for 1 to 3 days, and it can go to the spleen here and get a little bit more mature before it really goes out in the circulation. The normal amount of reticulocytes, basically we say 1 to 2% in the circulation is normal. This would be altered if certain states are happening, and when we get into anemia, we'll talk about that. But basically, if the reticulocytes are elevated, but higher than these 1 to 2%, we know the bone marrow is working, correct? So nothing in this process is altered. If we have low reticulocytes, then something's going on within the bone marrow because the reticulocytes are not being released. So then we think, is there infection? Is there malignancy? What's going on back here that is creating an issue with making the blood cells? And that's just how we use these processes to figure it out. So now you know where iron is, you know where B12 folate is. It's in this process, DNA precursors. And then you know where the reticulocytes are, what the reticulocytes are going to tell you. So this is going to be used all the time in trying to figure out the anemia etiologies. So then the normal blood cells, we all know this, 100 to 120 days into the circulation, doing their job, delivering oxygen and taking waste products away. The reticulocyte, this does vary, but we basically say, 1 to 2% is normal. And then if it's greater than 3, then it's a response to the anemia and it's doing its job trying to increase the red blood cells. Reticulocytes are the way that we determine if there's functioning bone marrow. So that's why reticulocytes are very high yield. So now we're going to talk about hemoglobin synthesis. And hemoglobin is that oxygen carrying protein of the erythrocyte, and it is responsible for taking up oxygen in the lungs and then exchanging it for carbon dioxide in the tissues. A single erythrocyte contains as many as 300 hemoglobin molecules. Hemoglobin increases the oxygen carrying capacity of the blood by 100-fold. So we have embryonic, which primarily are the product of the yolk sac erythroblasts, and detectable only in those early stages of embryogenesis. There are certain times that we get embryonic hemoglobin, and that would be in something like a severe alpha thalassemia. There are some variants here, zeta and epsilon, and they are named Gower1, Portland, and Gower2 variant. Fetal then is approximately the 14th week of gestation, and embryonic hemoglobin completely replaced by fetal hemoglobin HbF, and this has a higher affinity for oxygen than adult hemoglobin, and it allows that preferential transfer of hemoglobin from the maternal circulation to the fetal circulation. Then we get the adult hemoglobin, and that starts within the first year of life. This is the predominant form of hemoglobin, and this is the hemoglobin A, as for adult, and it is present in 95-98%. We do have some variants such as a hemoglobin A2, and that is responsible for about 2 to 3%, and then the hemoglobin F is less than 2%. Some other variations, we do have sickle cell, and then the alpha and beta thalassemia, hemoglobin E, and hemoglobin C. The sickle cell, alpha and beta thalassemias, hemoglobin C and E, all are related to protection against malaria. So they are common in those regions such as Nigeria, southern China, Africa, Congo, all of them because of the high malaria burden. So that has been a way that through variants that the hemoglobin is protective. Each hemoglobin molecule contains 2 pairs polypeptide chains and 4 iron complexes, which are iron plus protoporphyrin. So we have that classic picture of hemoglobin, and we have the erythrocyte, the hemoglobin molecule, and the heme molecule. The globulins are 2 pairs. So we have 1 pair, which is the alpha polypeptide, and a beta polypeptide. Beta 1, beta 2, alpha 1, alpha 2. Then in that knotted configuration of 150 plus amino acids, that's how we get these globulins. Then we have these iron units, and that is the heme unit, and this is where we are going to bind our oxygen. The heme is iron and protoporphyrin. Obviously, if we have issues with iron, lack thereof or loss of, then we are going to have less O2 binding capacity because we don't have 4 molecules per hemoglobin. It is going to bind iron in the Fe2 plus format, which is ferrous iron. Protoporphyrin, if there is an issue with this, such as a genetic issue, then we would have a sideroblastic anemia develop. And then obviously if we have issues with iron, we would have an iron deficiency anemia. Okay, so heme is that large flat iron protoporphyrin disc. So that's that heme group. So we have the iron in the middle of it. Here we have that protoporphyrin or porphyrin unit. And that protoporphyrin is a complex 4-ringed molecule. and it is produced with ferrous iron, so Fe2+. It is crucial that the iron be correctly charged. Reduced ferrous iron as Fe2+, so this is in a reduced state, and that allows for the ability to bind oxygen in the lungs and then release it in the tissue. Then the oxygen concentration is less, whereas ferric iron, which is 3+, cannot. Binding of oxygen to ferrous iron, which is called oxyhemoglobin, temporarily oxidizes Fe2+ to Fe3+, and there's an example of that up here. So that's the normal oxyhemoglobin equilibrium. After the release of oxygen, the body reduces the iron, and now this is called deoxyhemoglobin, and it's basically reduced hemoglobin, and that reactivates the hemoglobin's capacity to bind oxygen. Without reactivation by methemoglobin reductase, the body cannot bind oxygen. So the Fe3+ containing hemoglobin, which is referred to as methemoglobin, cannot bind oxygen. An excess of ferric iron occurs with certain drugs and chemicals. So this can be induced by nitrates, sulfonamides. So that is just that kind of process that goes back and forth. So that's why it is important to understand that iron does need to be in the Fe2+ state. If through that process that it remains in the Fe3+, then we have the development of methemoglobin. What is also important to understand when we have oxygen binding is that when we get one O2 molecule here, that is going to go bind to the first protoporphyrin and iron complex. It undergoes a conformational change when binding oxygen. So when we bind the first one, it actually goes over and changes the second one, so it has more affinity for oxygen. And then it continues on that per the 4. So as we get to the fourth one, it has an increased binding capacity, and that is a conformational change. This we'll talk about a little bit more when we get into the oxygen hemoglobin dissociation curve in the respiratory lecture. Next, RBC destruction. So do need to understand the normal destruction, basically cellular senescence of the RBC, so that you understand if we have atypical processes and what happens. So we have 100 to 120 days in the circulation. The old erythrocytes are removed by tissue macrophages, primarily in the spleen. We do have issues with the splenic dysfunction or absence of the spleen. Then the Kupffer cells in the liver take over. Kupffer cells are just tissue macrophages but reside in the liver. It's their name. And then what happens is the red blood cells are digested by phagocytosis and then dissolved by proteolytic and lipolytic enzymes that are in the lysosome. So we have that whole process that we talked about with lysosomal degradation pathway. This is happening with our red blood cells. What happens then is the hemoglobin dissociates very easily. The globin is broken down into the amino acids, so we have the bigger protein broken down into the smaller protein molecules. Iron is oxidized, forming methemoglobinemia, methemoglobin, Fe3+, and recycled. We have our heme unit. Heme breaks off to iron and then bilirubin. So porphyrin is reduced to bilirubin, which is transported to the liver, conjugated, and finally excreted as bile. There's approximately 6 grams of hemoglobin catabolized daily, producing about 200 milligrams of bilirubin. There are bacteria in the intestinal lumen that transform conjugated bilirubin into urobilirubin, and then a small portion is reabsorbed for further metabolism by the liver or excreted by the kidneys into urine. We can have issues that can cause accelerated erythrocyte destruction, and that would be an increased load of bilirubin for hepatic clearance. So you can directly measure the levels of unconjugated bilirubin and increased urinary excretion of urobilinogen to basically say that there is erythrocyte destruction going on. Another issue is that we could get gallstones, cholelithiasis as a result from chronically elevated rates of bilirubin excretion. So if you have a hemolytic process going on. So here is a nice kind of schematic of that whole process that I just talked about. We do need to understand iron metabolism and cycle because iron deficiency anemia is one of the big anemias that we're going to discuss. So approximately 67% of total body iron is bound to heme in the erythrocytes, so our hemoglobin. And then we have also in the muscle cells called myoglobulin. Approximately 30% stored in macrophages, hepatic parenchymal cells as ferritin or hemosiderin. And then we lose about 3% in urine, sweat, bile, and sloughing epithelial cells, such as in the internal mucosa and the skin. We require about 25 milligrams of iron for daily erythropoiesis. What is high yield is only about 1 to 2 milligrams comes from dietary sources. The rest is from recycling red blood cells. Some key terms as we move forward in iron metabolism. Ferritin is the major intracellular storage protein. Iron must be bound. If it is left unbound, then we will get reactive oxygen species. Apoferritin does not, so it's the ferritin protein, but it does not have an attached iron. So that would be apoferritin. Hepcidin, so this is what's going to regulate iron cycle. Hemosiderin is an iron storage complex of numerous micelles of ferritin, and then it forms large aggregates, and that is this hemosiderin. Transferrin is the transporter molecule in the blood. So let's talk about hepcidin. So this is the molecule that is going to regulate iron homeostasis, and hepcidin is made in the liver, synthesized in the liver. Hepcidin production is regulated by the body's dietary absorption, and then also the rate of erythropoiesis and level of oxygen saturation. If we need more red blood cells, we need more hemoglobin, we need more iron to be able to produce it, so that would make sense. So the hepatocytes sense levels of the circulating iron by means of receptors for transferrin, which is the major transporter in the plasma. Excess iron is stored in hepatocytes and macrophages. So those would be the ways that we are sensing the amount of iron. The other thing that can increase hepcidin is an inflammatory interleukin called interleukin 6, and that is by inflammation. So what happens when hepcidin is regulating the iron levels? It's relating it through its binding capacity to ferroportin. So ferroportin are these little proteins that allow for the iron cell to be transported or stored. So you're going to see ferroportin on the macrophages, hepatocytes, and enterocytes. The body's iron balance is maintained through controlled absorption rather than excretion. So what's going to happen if hepcidin is activated is we're actually going to shut down the ferroportin, and that allows for remaining in storage. So the iron is not going to be allowed out. Okay, so it's going to basically keep it away from going back into the circulation. It is going to keep it inside the enterocyte. So we are basically blocking the ability of the iron to be in the circulation. So why is this necessary? So microorganisms, they love iron, and it actually helps them proliferate to flourish. Decreased production of hepcidin leads to release of stores and increased dietary absorption. So increased hepcidin levels will do all of this. Decreased hepcidin will actually increase absorption and increase release. When we're talking about regulation of iron absorption, so this would be in the duodenum. And just so that you can see, we have two types of heme iron. So we have heme iron and non-heme. Heme iron comes from animal sources. Non-heme is from plant sources. So heme iron has to be bound. So this is a heme transporter. Remember, it's iron, so it must be bound. Non-heme iron is actually in an Fe3 plus state, and it needs to be converted by duodenal cytochrome B, and then we get into Fe2 plus state. The Fe2 plus state can then be taken across by this little transporter protein on the enterocytes and then taken into the enterocyte, and two things will happen to it. It'll either be stored as mucosal ferritin, or it will get processed through the ferroportin. If heme iron comes in, it is bound to a heme transporter protein. Here is that ferroportin. So those are the fates of heme as it comes in from our dietary sources. Okay, so let's take a look at B12 and folate, as these are going to have impact on our megaloblastic anemias. So both play a critical role in DNA and RNA synthesis. Humans cannot synthesize vitamin B12 or folates, so they must have a typical balanced diet that contain adequate amounts of both of these vitamins. So both of these play a very critical role in DNA and RNA synthesis, and deficiency can impair DNA synthesis, such as arresting cell cycle. There may be some replication errors and also undergoing apoptotic death. B12 is the principal cofactor in the reaction that recycles 5-methyl tetrahydrofolate back to tetrahydrofolate. This is coupled in the conversion of homocysteine to methionine. I have a schematic coming up here. So you can see here B12, methionine. We have a couple different methylation, and then homocysteine. So that's that pathway. When we talk about folate, the principal role is DNA synthesis, and it's job is to supply methyl groups to other molecules as a one carbon donor. So again, if we would take, so we have folate taken in, and then we have tetrahydral, and then we have 5-methyl, and that entire process and conversion requires that folate. So if we have problems with either B12 and folate, and a lot of times they can happen together, we're going to have major deficiencies in the hematopoietic system, and that's going to give us our megaloblastic changes and ineffective erythropoiesis. There are also neuronal changes with B12, and the exact mechanism is not known, but there are neuropsychiatric and neuro issues when we have B12 deficiencies. The other thing to remember about B12 is that we do need intrinsic factor for it to be absorbed. So we have food coming in, and then we have our gastric cells that are going to secrete hydrochloric acid and pepsin, break down the food, and then we have intrinsic factor released by these cells, and that is going to bind to the B12. The principal role of folate in DNA synthesis is to supply those methyl groups that are added to other molecules. And then the principal role of B12 is act as a cofactor in the reaction that recycles 5-methyl tetrafolate. The methyl groups generated during the conversion of SAM to S-adenohomocysteine, or SAH, are also used in other processes, including DNA methylation, that epigenetic modification, which we talked about, where the methyl groups are added to DNA and DNA binding proteins, and that leads to increased or decreased gene expression. So that's huge there with that methylation. Quick about what we would work up when we're talking about red blood cells. You need a CBC with differential so that you get your indices. Reticulocyte count, obviously we're trying to measure bone marrow. Serum iron studies, do you have an iron deficiency anemia, or do you have something else going on? Your iron studies will help differentiate that. IgA-TTG is related to celiac disease, and this would be something maybe is going on with absorption. B12 folate precursors, we need to see if that's a cause of the megaloblastic. Anti-intrinsic factor antibody, anti-parietal cell antibody, that goes back to this situation here. So these are your parietal cells, and then you have your intrinsic factor. Both of those could set you up for deficiencies related to your pernicious anemia. Serum methylmalonic acid levels, we are going back into this process, and we can actually measure and see exactly if we have deficiency in that. Imaging would all relate to our etiology. So are we concerned about a GI bleed? You need to do upper GI, lower GI. If we can't find a cause, you need to do maybe an exploratory laparotomy, CT scan. And then the specialized tests are, bone marrow tap and see what's going on with the bone marrow. When we talk about normal hemoglobin hematocrit, obviously it is going to alter with ages. So this is just something to be aware of. It is a good idea that you have an idea of what your normal amounts are. So let's take a look at the red blood cell indices. These are the main things that you're going to measure when we're talking about our red blood cells, and looking at what is going on with the actual cells on a smear and taking a look at them in the laboratory. All right, we have mean cell volume or mean corpuscle volume. Either one is correct. So mean cell volume or mean corpuscular volume, they're interchangeable. Cell means corpuscle. And that is going to be the size of the erythrocytes. So this is going to give us whether they are microcytic, macrocytic, or normocytic. And that will come into high yield when we're learning about diagnosing anemias. Next up is the mean cell hemoglobin. So this is the amount of hemoglobin per red blood cell by weight. The response should mirror the MCV. Next is mean cell hemoglobin concentration. So this is the percentage of hemoglobin in each erythrocyte. The red cell distribution width, this is the variance of sizes of the red blood cells. This will be elevated in things such as iron deficiency anemia. Then we have our reticulocyte count, and again, we talked about that earlier. It is the reticulus in the blood, and it is really evaluating the anemia by distinguishing from inadequate production versus accelerated destruction. So you are going to be hypoactive or hyperactive bone marrow. So the mean cell hemoglobin concentration does give us the color of the cell. So if there's normal hemoglobin, then we would call it normochromatic. If it is hypochromatic, then we are a certain type of anemia. So these erythrocytes are looked at on a peripheral smear, and then the morphologic examination includes assessment of the size, shape, and color. The shape is normally round and has smooth contour. There can be permutations in the cell shape, which is called poikilocytosis, and these can reflect changes and are important pathologic processes. So depending on what shape of the cells, then we can lead to what type of deficiency or pathologic process is going on, such as a megaloblastic process, where we would see those large oval-shaped or macroovelocytes, and then there may be some elliptical cells or some schistocytes, helmet-shaped pieces of red blood cells. All of that's going to lead to what they're involved in. Just want you to be aware, but these would be spherocyte, stomatocyte, elliptocyte, but it's all on their appearance under the microscope. All right, let's take a look at our iron function. So this is hemoglobin metabolism testing. For now, I just want to go over the basics of what you would see in iron function testing. Total amount of iron in the serum, you have your norms. TIBC stands for total iron binding capacity, and this is the amount of iron that can be bound to proteins. It is an indirect measure of transferrin. Transferrin is a direct measure of the carrying protein that iron would be bound to. Transferrin saturation is the amount of transferrin that is saturated with iron. So we know that in a normal situation, about 33% of the occupied sites are saturated. Serum ferritin reflects the total body iron storage. Just some quick notes related to changes related to age. We have higher red blood cell counts at birth, related to accelerated hematopoiesis during the fetal life as response to changing in O2. And then we do have a lot of reticulocytes because we have accelerated hematopoiesis, but usually by early childhood, we are to normal, having that 100 to 120 day erythro cycle. When we get to the aged, we have little composition changes as we age, but we do have some iron depletion because those stores are depleted. And then we also have a lot of chronic disease, which is going to suppress erythropoietin and as well as have impact on iron. Now we're going to take a look at the red blood cell disorders, anemias, myelodysplastic syndromes, hemoglobinopathies, volume contraction, polycythemias, and then there are some other situations. Anemia is the reduction of circulating red blood cells, either by reducibility or quality quantity. Rate at which anemia develops is as important as the severity. A rapid decline will overwhelm the compensatory mechanisms of the body, and that is going to lead to your hypovolemic or cardiogenic shock. If you have a slow developing anemia, then that will allow for compensatory mechanisms by the body, and it will not overwhelm the system and cause collapse. Mechanisms by which the anemia can occur are excessive red blood cell loss, abnormal red blood cell destruction, inadequate or ineffective red blood cell production. There will also be morphological characteristics that are going to lead you to be able to take a look at what causes those mechanisms. When we talk about anemias, we have multiple etiologies, we have multiple types of anemias, and here is just kind of the big ones. We're really going to take a look more at the pathogenesis and then what are going to be the causes of it, and then understanding what the tests are looking for. There are two ways that we approach anemia classifications, either the kinetic approach or the morphologic approach. The kinetic approach looks at the underlying mechanism in red blood cell loss. I'm going to give you ways that you can look at both of these and understand one as kinetic or one as morphological. So the kinetic is really looking at is there a decreased RBC production, is there an increased RBC destruction, or is there blood loss? Morphologic is going to look at the evidence that we have by micro, normo, or macrocytic, and allows us to classify our anemias that way. So I have these nice little schematics to the overall approach to anemia, and I both have the kinetic approach and the morphologic approach for you. So whichever one works for you, however you want to classify it so that you understand, but you need to figure out one way that you're going to be able to approach anemia. So this is the kinetic approach, and we're looking at blood loss, decreased RBC production, or increased RBC destruction. And then it breaks it down as into what's going to fall in those. Blood loss, acute or chronic bleed. When we talk about decreased red blood cell production, we would have normal or decreased reticulocytes, all depends. We're looking really at our iron deficiency, B12, aplastics. Increased red blood cell destruction, we're talking about hemolysis here. We have two types, congenital versus acquired, and we would have increased reticulocytes because we have destruction in the periphery. We need to increase the reticulocyte by increased bone marrow production. And we would also be having evidence of red blood cell destruction in the periphery. So we would have increased unconjugated bilirubin. When we take a look at the morphological approach, we are really needing the ability of you to have your indices because you need to be able to see what the MCV. So this is based off of the MCV, the mean corpuscle volume, and we have less than 80. We have normal 80 to 100, and then we have greater than 100 microcytic, normocytic, and macrocytic. Regardless of what type of anemia you have, we do have generalized symptomology that is related to the decreased oxygen carrying capacity and getting things where they need to go, such as fatigue, weakness, shortness of breath, dyspnea, and air hunger. And then we have loss of red blood cells, so we lose our coloring and the conjunctivae and vermilion, overall pallor colored. Palpitations, tachycardia, and these are compensatory mechanisms. So let's take a look at the microcytic anemias first. Again, referring back to whether it's microcytic, normocytic, or macrocytic, we're going to be focusing here right now. So we're going to cover the microcytic anemias. So iron deficiency anemia, this is due to a decreased production of hemoglobin. Remember that we have those RBC progenitor cells in the bone marrow. They're large and they divide multiple times to produce smaller mature cells. What happens to make this a microcytic is that due to the less amount of hemoglobin, the body's compensatory mechanism is to make smaller cells and to maintain hemoglobin concentration. So normally we, just for illustration purposes, we have those 4 hemoglobin molecules, times 300 per erythrocyte. Well, what happens when we have less hemoglobin synthesis due to iron deficiency, then the body actually will make another cell division, making a smaller cell so that we have maybe 2 hemoglobin or 150, but the saturation will be the same. So we would still be 100% saturated just on a smaller cell. We don't have to have as many hemoglobin molecules to hit that saturation. So that extra division is to maintain that hemoglobin concentration per erythrocyte. So that's how we get smaller cells. We talked about hemoglobin synthesis, so iron and protoporphyrin, and a decrease in these components leads to anemia. We're not talking about the globin portion of the hemoglobin process, we're talking about the heme portion. So if we have decreased iron levels, we have decreased iron, decreased hemoglobin equals a microcytic anemia. It is the most common type of anemia, and we have a couple different ways that we can get iron deficiency anemia. So if we would have a dietary insufficiency or deficiency, the ways that we would see this was lack of green leafy vegetables or meats. Remember those heme and non-heme versions. Where would we see this? Anybody that has dietary issues, such as patients who don't eat vegetables, those who don't eat meat, and then you would also see it in infants who are breastfed because there's no iron in breast milk. Less than 6 months, infants. Another way would be impaired absorption. So things that would affect stomach acid, such as a PPI or maybe a gastrectomy. This could be a gastric sleeve or a Roux-en-Y bypass. Also maybe celiac disease. We talked about that maybe we need to test for that. Those would all impact absorption on those enterocytes. Increased requirement. So we would see this if we needed to increase blood volume for any reason. So that would be pregnancy. Maybe we have child growth spurt. Chronic blood loss. So this is going to be high yield for a certain group. Women of childbearing age, we would be looking at menses, right? So is there a heavy menses? That may lead to the development of an iron deficiency anemia. In the geriatric population, we would be looking at a colonic bleed or a cancer. So if we see an iron deficiency anemia, which is usually found incidentally, We would definitely be concerned for colon cancer, and that's one of the first things that we work up. Other thing may be peptic ulcer disease. Do we have an upper GI bleed versus a lower GI bleed? And peptic ulcer disease would be an example of that. So those are the four ways that we get iron deficiency anemia. Again, iron is transported and absorbed in the duodenum, and the enterocytes transport across the cell membrane via to that blood via the parafortin. Transferrin transports to liver, bone marrow, macrophages for storage or use within the erythropoiesis. Intracellular or iron is bound by ferritin, which prevents that free radical damage via the Fenton reaction. And that is that process we talked about with the formation of hydroxide. Remember that bad free radical and hydrogen peroxide. So that is the Fenton reaction. All right. So again, we talked about laboratory status earlier and what we would be looking up. So here is just another schematic of that and a nice little way to look at it. So let's take a look at the expected results when we're talking about an iron deficiency anemia. So serum iron is measured, and it is the amount of circulating iron, which is mostly bound to transport protein, and it is low in iron deficiency. Serum transferrin, so this is the circulating transport protein. It would be increased in iron deficiency anemia because we're trying to upregulate and find as much iron as possible. So we need more molecules to transport iron. The transferrin can again be represented by the TIBC, which is the total iron binding capacity. And again, that would be related to the serum iron and the transferrin saturation. Total iron binding capacity would be increased because it's a direct measure. These two are linked, and that's why I have these here. Transferrin saturation, however, would be reduced because we are not going to have those sites occupied because we have a lack of iron because we don't have the iron to saturate the receptors. Serum ferritin is that iron storage protein, but also with ferritin, it is an acute phase reactant. We talked about this a little bit in the inflammatory response. So that can be independently raised, independent of iron status, and you would bounce that off. Is there infection, inflammation, certain malignancies, liver, heart failure? If you're looking at it in the presence of iron deficiency anemia, then the serum ferritin would be reduced because there is lack of total body iron. Some signs and symptoms, in addition to what we talked about with those generalized signs and symptoms, some that are specific to iron deficiency are pica, and then the spooning of the nails. In addition to the pallor, dyspnea, you can have some restless leg syndrome, glossitis, or angular stomatitis, which is kind of those cuts that you get at the where the two lips meet, and you can have some hair loss, gastric difficulty, and dysphagia. Okay, next up is anemia of chronic disease. So this would be associated with chronic inflammatory responses, chronic diseases. So anemia of chronic disease is due to acute phase reactants from the liver, including hepcidin. So we talked about hepcidin controlling iron absorption. This is where anemia of chronic disease comes in. We're actually working on the hepcidin molecule. So again, a synopsis of the hepcidin limits iron transfer from macrophages to erythroid precursors, suppresses erythropoietin, and also aims to prevent bacteria from accessing iron, which they need for survival. And that's what we talked about with hepcidin earlier. Key differentiation for anemia of chronic disease versus an iron deficiency anemia, because they would both likely present the same way. However, you're going to have some type of chronic disease, whether cancer, autoimmune, kidney, all of those would help with your differential. Again, looking at hepcidin, remember that it is going to control these ferroportin channels. And if we have hepcidin that is altered and we have increased amount of hepcidin, then we shut off iron metabolism. The reason we do that is so that the microorganisms do not gain access to the circulating iron, which they use. When we take a look back at our labs, when we talk about anemia of chronic disease, you would still need to pull iron function, again, because they're going to present in the same way. However, the anemia of chronic disease is going to have different levels. The body is going to try and keep away the iron from the microorganisms. So just remember that, play keep away. In serum iron, it would be still decreased because that's the blood amount, that's the blood iron. and the body's trying to play keep away, so we're going to keep it out of the blood. The total iron binding capacity is also going to be decreased because, again, we're playing keep away. We don't want our transferrin, our iron binding capacity, to be upregulated because we want to decrease iron synthesis. In that respect, transferrin, TIBC mimic each other, and they would both be decreased. The transferrin saturation will also be decreased. Again, we're playing keep away, so we don't want all our sites occupied, so they're going to be lower. Now, the serum ferritin is going to be elevated. Remember, this is the storage. So we are taking it out of the blood system and we are keeping it in the storage system. So your storage ferritin, your serum ferritin, is going to be increased. We are tucking it away, keeping it away from inflammatory state to be utilized. Let's take a quick look at thalassemia anemias. This is related to the globin change. So now we're moving on to the globin part of the hemoglobin. This is inherited, and again, it's related to that protection from malaria. And we have two types, alpha and beta thalassemia. So we have major and minors. We have a severe thalassemia. This is diagnosed earlier in childhood, and it's genetic. So we would see this early if it's severe enough. And then the child will be transfusion dependent. Thalassemia minor may not be diagnosed until adulthood because there's not major changes related to the hemoglobin molecules. The way that you would be able to distinguish this is performing hemoglobin electrophoresis, and this is most often seen in patients of Mediterranean descent. Another one that would be on the hemoglobin line. So this is going to be related protoporphin area and inherited or acquired. And if it's inherited, it's X-linked, rare genetic condition. Acquired may be related to drugs such as tuberculosis drugs. It's a disruption of protoporphyrin. Sideroblastic anemia can cause liver damage and hemochromatosis. And key differentiation, if it's acquired, alcoholism can be a reversible cause of sideroblastic. Otherwise, it would be X-linked genetic. And then you would be able to have some hepatosplenomegaly in about 1/3 to 1/2 of the patients, and that's how we would, on differentiating the anemias, that would be a high yield finding. Okay, now we're going to focus on macrocytic anemias, especially looking at folate deficiency and vitamin B12. In addition, we'll take a look at some other etiologies. So now we're going to be over here on the macrocytic. So the MCV would be greater than 100. We have two basic types, megaloblastic or non-megaloblastic, and you can see the classifications. Drugs is a little confusing because we actually can have drugs on both sides. So it's really what do you find on your evidence to say if it's megaloblastic versus non-megaloblastic. An MCV greater than 100, certain etiologies will give you higher MCVs, such as 115, 110, and usually if they're in that range, we're thinking it is definitely a folate or vitamin B12 deficiency. The normal physiology of the folate and B12 synthesis, and remember that it's necessary for those DNA precursors. If we have issues with that, which will ultimately lead to the enlargement of the red blood cell precursors, which gives us these macrocytic blood cells. It will also then impair division of neutrophils, and we will have hypersegmented neutrophils. So that would also be present on your smear. Other etiologies of macrocytosis include alcoholism, liver disease, certain drugs that do not change megaloblastic. Drugs that would impair DNA precursors are how you are going to differentiate megaloblastic versus non-megaloblastic. So those drugs that would interfere with DNA synthesis would be something like your methotrexate, your methaprim. So these drugs on DNA synthesis would offer the megaloblastic changes. Ones that would cause hemolytic anemia, which would also increase the MCV because we're going to be pumping out a lot more red blood cells, could be something like penicillin, methyl-dopa, cephalosporins, just to name a few. So the folate deficiency, absorbed in the jejunum, foods that are green veggies, some fruits. Folate deficiency is really affected by alcoholism, elderly if they're not having a good diet, and then if there's increased demand, such as in cancer, pregnancy, or there's a hemolytic anemia present. And then those drugs that would be altering folate, such as methotrexate. What's interesting about your folate deficiency is that it can occur over a few months. If it is caused by alcoholism, if the patient would stop drinking, it usually can revert back. So it's not a permanent situation related to that. Then the impaired liver disease too, related to the alcoholism, that could also have problems with that situation. Patho DNA synthesis labs, you're going to be pooling folate, B12, in addition to all those labs that we talked about in the beginning of the red blood cell lecture. If B12 and folate are borderline, then you would want to draw methylmalonic and homocysteine levels. And then that's also, we're going to be looking for that process in the methylmalonic and homocysteine levels, and that would aid in confirming that there is a B12 or folate deficiency. For vitamin B12 deficiency, again, we have to have intrinsic factor. This is animal derived. So this is where your strict vegans are going to have problems because B12 is only from animal derived proteins. Less common than folate, and it takes years to develop. Cofactor important in fatty acid metabolism, and that's why we have those neuro issues because of the myelination that can lead to demyelination. Most of the time when we do B12, you are going to pull B12 and folate together, and then again, borderline methylmalonic and homocysteine levels will help you differentiate. So another way looking at it, the macrocytic anemia, then you would look at your reticulocyte, and then your reticulocyte's going to help you differentiate. And then you're also going to see, are there hypersegmented neutrophils? So what we're looking over here is, are there megaloblastic changes? That's when we're looking at probable B12 and folate deficiency, and that MCV is greater than 110, 115. If they're normal and there is no hypersegmented neutrophils and MCV is less than 115, then you're going to go to these other potential causes, such as hypothyroidism, Down syndrome, certain medications. If those are all excluded, you don't have an etiology, then you're maybe looking at a myelodysplasia. So if you go over here with macrocytic anemia and the reticulocyte count is high, remember that means the bone marrow is active and working and doing what it's supposed to be doing in response to red blood cells. Then you're thinking hemolysis, blood loss. Here is megaloblastic versus non-megaloblastic drugs that interfere with DNA synthesis. So again, this would be your methotrexate, anything that is going to impair DNA. If you're suspecting that there's an autoimmune process going on, you need to test the TSH and see if there's maybe a Hashimoto's thyroiditis for that autoimmune process, because that would then put it at higher risk for this megaloblastic anemia. Malabsorption issues such as celiac or Crohn's disease. And when we're talking about key differentiation, we're looking at certain signs and symptoms such as a red swollen tongue that is high yield with folate. And then in your history, you're going to have signs and symptoms that are consistent with the megaloblastic causes. Non-megaloblastic key differentiation, are any of these things present? Other stigmatas with chronic alcoholism and liver disease. So you have evidence of chronic alcoholism and liver disease by signs and symptoms. Other things that would add to it is benzene petroleum exposures. If you have fevers, chills, malaise, weakness, think myelodysplastic syndrome. Normocytic anemia, normal sized blood cells. Usually we are going to see these with a hemolytic or a hemorrhagic anemias. So now we're going to be in the middle category, and this is a normocytic, so it's MCV between 80 and 100 femtoliters. And then you're going to again look at your reticulocyte count. Anemia with red blood cells that are normal due to two mechanisms: increased peripheral loss or destruction, or underproduction in the bone marrow. Again, you're going to use your reticulocyte count to help determine what's going on. So your normal reticulocyte count is 1 to 2%. Less than 2%, greater than 3% would indicate peripheral loss and anemia. The bone marrow is increasing production because we have less red blood cells. That determines it's working. If you have determined that you have blood loss and your reticulocyte is not increasing, then you would be concerned that there's something going on in the bone marrow. So the reticulocyte is very informative when the reticulocyte count is either very decreased or very elevated. If it falls kind of in those normal ranges or right around the normal ranges, you kind of have to do a little bit more investigation. And it's most helpful using reticulocyte parameter that is corrected for the degree of anemia. For reticulocytosis, you need normal functioning bone marrow. So you need iron, folate, B12, copper, good kidneys, the ability to sense decrease in oxygen. So we need that entire pathway to be intact and respond to erythropoietin. So now let's talk about the two mechanisms that we associate with normocytic, normochromic, increased peripheral destruction and loss, hemolysis. So one of the main mechanisms here is anemia due to blood loss. Acute versus chronic blood loss is what you have to determine here. Acute would be a loss of intravascular volume, and extremely massive would lead to cardiovascular and hypovolemic shock. Chronic, this is going to be related to a lower GI bleed, colon cancer. And you're probably going to see more of an iron deficiency anemia present than you will see the anemia due to blood loss. However, you can have compounding and you can have both. Trauma as the main cause of acute. So those are the main things with blood loss. When we are talking about hemolytic anemia or hemolysis, it should be considered when there's a rapid fall in hemoglobin and an increased reticulocyte count in the absence of overt blood loss. So these are going to be your hemolytic anemias, and you will basically get peripheral destruction. We have two types, intravascular or extravascular. You ultimately end up with a shortened red blood cell lifespan, and we would have elevated erythropoietin levels secondary to the fact that we have less red blood cells in the circulation. We will then get accumulation of hemoglobin degradation products. We're referring back to that process of the red blood cell pathway when we talked about these hemoglobin degradation products, because remember, we are going to recycle. Even if there is a problem in the blood system and we have that hemolysis, we would still try to recycle our red blood cells. Multiple etiologies here. It's immune mediated, inherited, genetic. So immune mediated would be something like paroxysmal cold hemoglobin, drug-induced hemolytic anemia, cold agglutinin disease. And then inherited genetic, these would be your hemoglobinopathies, red blood cell membrane defects, enzymatic defects. So here we're going to get more of our hemoglobinopathies. So when you break it down into extravascular versus intravascular, it's whether it is within the blood system or outside of the blood system. If we're talking about extravascular, we're talking about the reticuloendothelial system. That is our splenic macrophages, liver, and lymph nodes. We are going to have evidence of extravascular destruction, and that would be hyperbilirubinemia, jaundice, and splenomegaly. We would also have those bilirubin-rich gallstones and the risk of cholelithiasis. Back in the physiology, the porphyrin gets broken down into the bilirubin, about 200 milligrams per day. If we have extravascular hemolysis, then we are going to have a lot more bilirubin. It's going to overwhelm the clearance of it, and then we have the excess hyperbilirubinemia due to that fact. Intravascular is going to be destruction of the red blood cells within the blood vessels, and those are related to mechanical forces such as heart valves. There can be biochemical or physical agents, and then we would have a loss of iron and presence of hemoglobinemia, hemoglobinuria, and hemocistinuria. The red blood cells are remarkable, and they go through a lot of mechanical stress just going through the microcirculation in and out all the time. So they are quite pliable, and they really have that elastic recoil, and they actually do not deform very easily. This happens millions of times over the course of that red blood cell lifespan. Some properties of the red blood cell that allow this to is that highly deformable membrane, their underlying cytoskeleton, the way that they're shaped. Hemolysis occurs when that red blood cell is unable to maintain its intact structure during those passages through the microcirculation as well as that reticuloendothelial system. The other thing too is it intracorpuscular or extracorpuscular, and that would be, are there changes in the hemoglobin structure function, membrane, cytoplasmic, so that would be intracorpuscular. If it's extracorpuscular, then we're looking at premature loss of membranes, membrane structural damage. Are there changes in status that are going to alter the cellular proteins? If we're talking about intracorpuscular, we're really looking at hemoglobinopathies such as sickle cell, thalassemia, and unstable hemoglobin variants. If we're looking at cytoskeleton or membrane defects, then we would be looking at hereditary spherocytosis, stomatocytosis, elliptocytosis, but we're really looking at suboptimal membrane surface to area ratio. So it's actually going to affect the membrane of the red blood cell. Metabolic abnormalities would be looking at deficiency in glucose 6-phosphate dehydrogenase, so that's G6PD, or pyruvate kinase, which is PK. And that's the metabolic capacity of that red blood cell. So remember, the red blood cell can do glycolysis and it's anaerobic. If it's extracorpuscular defects, so these would be looking at red blood cells are normal, but they're destroyed due to those mechanical, immunologic, or infectious problems. So that would be antibodies, so that would be immune mediated. Is there hypersplenism, meaning that the red blood cells get trapped within the spleen? Is there mechanical trauma secondary to high velocity jets, such as a cardiac valve that is not working or ventricular assist devices? Are there fibrin strands across vessels that are shearing the red blood cells? That is what we see in TTP, hemolytic uremic syndrome. Is there any issues with oxidant potential, such as certain drugs? And then methemoglobinemia or unstable hemoglobin variants, such as exposure to sulfonamides. And then, are there any pathogens present? So the big pathogens that would be causing a hemolytic anemia would be your malaria, babiosis. So you can see there's a wide etiology of how we get hemolysis. So now what happens with the intravascular versus extravascular? Okay, let's first look at extravascular hemolysis. So this is going to be in the splenic system or the reticuloendothelial system or the mononuclear phagocyte system. Any of those, they all represent the same thing. So what's going to happen is some damaged RBC, however that happens. So we're going to have an abnormal RBC, whether that is by maybe IgG, IgM, which would activate complement. IgM would activate opsonization and give us easily phagocytosed red blood cells. We also could maybe have some sickle cell abnormalities or spherocytosis, whatever. The starting thing is an abnormal red blood cell. So then the splenic macrophage system will start to break it down. When we have a red blood cell, inside the red blood cell is also this thing called haptoglobin, just another enzyme that is present with it. When we get the breakdown of the red blood cell, we are going to break down not only the heme, the globin, but we're also going to release that haptoglobin. So because the red blood cell is being destroyed, the haptoglobin would actually be on the lower side, so it would be decreased levels. That same process, we get the heme broken down, so we have that protoporphyrin, and we have the iron. The protoporphyrin gets turned into bilirubin and it's unconjugated until it gets into the peripheral. So it's unconjugated until it gets to the liver. So what's going to happen in extravascular hemolysis is that the liver is going to be overwhelmed because it is not able to contain the amount of red blood cell degradation products. So there's going to be increased protoporphyrin levels. There's going to be increased unconjugated bilirubin. Basically, this is going to be problematic for the liver, and we are going to not be able to facilitate its clearance rather well. Another thing that would happen is an increase in lactate dehydrogenase, which is LDH. So those are present in most all cells as well. And when we get lactate and pyruvate and that lack of oxygen, LDH would be increased because of that process of the lactate and pyruvate. So for extravascular hemolysis, decreased haptoglobin, increased protoporphyrin, increased unconjugated bilirubin, and we would have increased lactate dehydrogenase.
Hey, Dan. See you got new homeowners insurance. Yeah, one with the alpaca. I'm not really sure what it covers to be in. Greetings once again. Today's topic is intravascular. Include intravascular versus increased unconjugated bilirubin and low haptoglobin. In the next video, you'll discover that these are not unique. Intravascular hemolysis. The hemolysis occurs inside the blood vessel. Fine. Why? Maybe a complement is mediating a damage and destruction to the nice red blood cell. Maybe an enzyme defect, such as glucose 6 phosphate dehydrogenase deficiency. Also, maybe a valve, a calcific aortic valve that's so thick and calcified and stiff that the RBCs, in order to get through the valve, they have to be sheared and smashed into a schistocyte, which is a sheared red blood cell. This is called macroangiopathic hemolytic anemia, because the pathology is big. The valve, the calcific valve, is something macro. There is also a microangiopathic hemolytic anemia in conditions such as DIC, disseminated intravascular coagulopathy, HUS-TTP, which is hemolytic uremic syndrome, and TTP is thrombotic thrombocytopenic purpura. HELP syndrome stands for hemolysis, elevated liver enzymes, low platelets. There is a song which is DIC, TTP, HUS, help me. DIC, TTP, HUS, help me. Microangiopathic hemolytic anemia. What happens is that the platelets get clumped together, so the platelets are consumed, and also the coagulation factors are consumed as well in a very big clump like this, or a very big clot. Again, the RBCs, in order to pass in the blood vessel, get smashed and sheared into a schistocyte, sheared red blood cell. All of this occurs where? Inside the nice blood vessel. There is a giant blood vessel. Okay, that's why it's intravascular hemolytic anemia. And this was the mechanism of the extravascular hemolysis discussed in the previous video. Now to the intravascular hemolysis. Again, complement, enzyme, macroangiopathic or microangiopathic hemolytic anemia. There is a problem with the red blood cell. Okay, the red blood cell gets destroyed by macrophages again, but not in the spleen, in the blood vessel. Fine. Then this RBC has hemoglobin and it's bound to the haptoglobin. When haptoglobin gets attacked, hemoglobin gets attacked at the same exact time. And of course, you know that hemoglobin has heme and globin. Heme has protoporphyrin. Protoporphyrin turns into unconjugated bilirubin, goes to the liver to be conjugated. So, will I see increased unconjugated bilirubin in intravascular hemolysis? Absolutely yes. Many students confuse this point. They think that unconjugated hyperbilirubinemia and jaundice only occur with extravascular. That's not true. They occur in both extravascular hemolysis as well as intravascular hemolysis. There is hemoglobin because the RBCs are destroyed. Whether they're destroyed in the blood vessel or in the spleen, doesn't matter. Hemoglobin is destroyed and attacked, and hemoglobin has heme, which has protoporphyrin, which is converted to unconjugated bilirubin that goes to the liver. Normally, the liver can handle all of the amount of unconjugated bilirubin, but when there is hemolysis, the liver is overwhelmed and tired and cannot do all of that, so the levels of unconjugated bilirubin increase. In order for you to have the symptoms of jaundice, which is the yellow discoloration of skin and mucous membrane, you have to get, and the sclera, you have to get the unconjugated bilirubin level more than 2.5 in order for you to have jaundice. That's fine, but there's another story. When we have discussed extravascular hemolysis in the previous video, this destruction occurred in the spleen. The spleen can use the iron, the spleen can use the globin and destroy it into some nice amino acids, and it's kind of okay. But the spleen cannot handle the protoporphyrin, that's why we have elevated unconjugated bilirubin. But in intravascular hemolysis, the process occurring in the blood vessel, some of this hemoglobin unfortunately will go as it is, as a hemoglobin, to the kidney, of course, because this is the blood vessel and the kidney has a nice renal artery going into it. So some hemoglobin will go to the kidney, actually a lot of hemoglobin. Some of it will just be secreted in the urine, giving us hemoglobinuria. Hemoglobin in the urine. The kidney will try to reabsorb some of the hemoglobin. And the hemoglobin has heme, which has iron, and the kidney tubules can store it in the form of hemosiderin. Eventually, these tubule cells will get sloughed off and are excreted in the urine, giving us hemosideриnuria. So, what are the lab results of intravascular hemolysis? How about decreased serum haptoglobin? Yes, indeed. How about increased LDH, lactate dehydrogenase enzyme? Yes, indeed. How about increased hemoglobin level in the blood and in the urine, hemoglobinuria? Yes, indeed. How about hemosiderin urea? Of course, it will happen. This hemoglobin is lost in the urine and the hemoglobin has iron. Can I get iron deficiency? Of course you can. So all of these occur in intravascular hemolysis.
So when we look at the intravascular hemolysis, so it's within the blood system, and this can be related to those causes as well. It's just not happening in the spleen; it's happening into the intravascular complexes, intravascular system. So we could have maybe a complement issue, such as the MAC complex, and that was your C5 through 9. Whatever. We could also have maybe a G6PD issue, or we could have maybe a valve issue. Something's causing shearing of the red blood cells. So when we talk about those valves, we do get this situation where we have evidence of it. So as the red blood cell moves through an area with that high turbulence, it will actually come out and look differently. And we call those schistocytes. And that is just basically a sheared red blood cell. So schistocyte. That's one of the ways that we can say that there is intravascular hemolysis, and we think that it is related to the shearing forces. The other thing where we would see schistocytes would be in TTP, DIC, HUS, HELP syndromes. So regardless of the cause, the red blood cells are being destroyed within the vascular, and they are not going to the spleen. So most of this is going to be handled by the kidney. You will still have the breakdown of heme and iron to protoporphyrin. And then you would have an increased unconjugated bilirubin, right? Again, the protoporphyrin is getting broken down and it's going to be in the peripheral blood before it goes to the liver. So you would still have an increased unconjugated bilirubin. If there's enough unconjugated bilirubin, we can still get jaundice. So you can still have jaundice with intravascular hemolysis, depending on the levels. The other thing to consider is that the kidney is where most of this is going to be handled because your blood supply, 1/20th, goes through the kidneys. We're bypassing the reticuloendothelial system. So you will have hemoglobin that is going to be present in the blood. You're also going to have hemoglobin that is going to get stored over here into the kidney. And that's going to potentially have iron storage as well. And that is going to be your hemosiderin. And then that is going to be processed and go out into the urine. So that's where you get your hemosideruria. Remember that hemosiderin is just large complexes of iron deposition. You will have your hemoglobinuria because you're going to have hemoglobin within the kidney capsule, and that is also going to get spilled out into the urine. Your kidneys are going to work at reabsorbing, and that's where all of this process happens. And then we have the ability of them to tumble over into the urine system. So those are the big differences between extravascular hemolysis and intravascular hemolysis. So understanding those levels. For the blood test for this, you would still have decreased haptoglobin because you are going to be having decreased hemoglobin because you're breaking it down. So whatever haptoglobin that follows the hemoglobin. You're going to have increased LDH because, again, that's present in all those cells, and it's just related to the lactate and the pyruvate. And then you are going to have increased conjugated bilirubin, but you're also going to have evidence in the urine as well.
Low haptoglobin, increased hemoglobin in the blood and in the urine. Hemoglobinemia, hemoglobinuria, hemosiderin-uria, and of course iron deficiency anemia because you're losing the iron. That when the red blood cell gets destroyed, lactate dehydrogenase will increase in the serum. That's intravascular hemolysis.
So let's take a look at hereditary spherocytosis. This is an autosomal dominant. The pathogen is an inherited defect of the red blood cell, and it's going to be related to a membrane tethering protein, and it leads to the spherical shape of the red blood cell. Then it is going to be involved in extravascular hemolysis. So that's going to give you the clinical signs and symptoms of that jaundice, increased unconjugated bilirubin secondary to the unavailability of the liver to clear it, and then increased risk of gallstones, just like we talked about. And there is just that pathway. So anemia, pallor, splenomegaly, which would be high yield because we have that extravascular system, and jaundice, again, secondary to that extravascular hemolysis, fatigue, all the other signs and symptoms of your anemias. You would draw a CBC with diff, and what do you think your reticulocyte count would be? The reticulocyte count here, unless there is some other issues of erythropoiesia, but the reticulocyte count will always be elevated, even if the patient is not anemic due to the mechanism of action. So abnormal red cell morphology of the spherocytes would be present. Your reticulocyte count is going to be elevated, and that can range anywhere from the 3 to 10%, all depends on the severity of the anemia. Your LDH, haptoglobin, and then we would do a Coombs test here as a confirmation of When we would do the workup for hereditary spherocytosis and the clinical presentation, anemia, splenomegaly, jaundice, all high yield, where you have that evidence of that extravascular hemolysis, and that's where we get that splenomegaly and jaundice. Your diagnostic workup, CBC with diff, and you would have evidence of MCHC would be elevated. Your MCV would be normal or reduced. Usually this we're talking about normocytic anemias right now, so your MCV would be normal. MCHC would potentially be elevated. And then your reticulocyte count is going to be elevated, and this would be anywhere from 3, and it can go high as 10%, so it can go pretty elevated. Your peripheral blood smear is going to be pathognomic for spherocytes. Your LDH would be elevated. We just referred to the pathways that we talked about. Your haptoglobin would be decreased, and you would perform a direct antiglobulin test, and this would be negative. Because we're trying to rule out if there is an autoimmune hemolysis here versus the hereditary spherocytosis. Because it's hereditary, you would need genetic analysis. But the presence of those other things are usually enough. So we would have diagnosis by increased red cell turnover, reticulocytosis, plus or minus anemia, typical spherocytes on the blood smear, and associated absence of an immune cause, and that's the direct antiglobulin test. Sickle cell anemia, so this is also a normocytic with extravascular hemolysis, and this is also autocessive, and this is going to be autosomal recessive mutation of that beta chain of the Take 2, sickle cell anemia. Sickle cell anemia, so it is a disease of the red blood cells, and it will be evidenced by normocytic with extravascular hemolysis, and it is autosomal recessive, and that mutation is in the beta hemoglobin chain, and that results in the production of hemoglobin that results in the production of the hemoglobin S, hemoglobin sickle. Basically what happens is those sickle cells will obstruct blood flow, break down prematurely, and then we have that extravascular hemolysis. This is, again, protective against malaria. This is where this variant came from. You must have 2 genes present for the disease because it is autosomal recessive. It is diagnosed by hemoglobin electrophoresis, and the disease you would have 90% hemoglobin S, maybe 8% hemoglobin fetal, 2% hemoglobin A2, but you would not have any of the normal hemoglobin, which is hemoglobin A1. If you would have trait, then you would have more HbA, less HbS, and less HbA2. Hemoglobin fetal is protective in the first few months of life, so you may not see it present right away. Greater than 90% of hemoglobin S in the red blood cells. You will have hypoxia, dehydration, and acidosis, and that will set you up for the vaso-occlusive crisis, which is the problematic situation for the patients with sickle cell. Here is just a look at what we get. So we get that point mutation from hemoglobin A over to hemoglobin S. We're going to have issues with oxygenation. We get that sickling. And then we would have extensive membrane damage, and then also issues in the microvascular circulation, creating occlusions. Your history and clinical presentation would include that there is a family history. This is autosomal recessive. It will present usually in early childhood and anemia, pallor jaundice, aplastic crisis, vaso-occlusive crisis, which can be pain, shortness of breath, depending on where we are getting the crisis, dactylitis, fevers, and pneumonia chest syndrome. Dactylitis is swollen hands and feet. And this can be a presenting symptom in young infants and children. By 2 years of age, 25% and 50% of Jamaican children with sickle cell will experience at least one episode of dactylitis, so it is quite common. Most of your signs and symptoms are related to the sickling of the red blood cells within, let's say, the pulmonary vasculature for the chest syndrome. The temperature would be related to the ability for a potential infection that is maybe the cause of it. Lots of bone pain. And then we would have all the signs and symptoms of the extravascular hemolysis. So that would be your jaundice. CBC with DIF, you're going to, again, this is going to be our normocytic. So your MCV is going to be between 80 and 100. Your MCHC, your reticulocyte count is going to be elevated. Your MCHC may be elevated as well. This is normocytic. So we would have an MCV that is normal, so 80 to 100 femtoliters. Peripheral blood smear is going to show the sickling cell, and you can see it down here. Genetic testing, obviously, because of autosomal recessive. X-rays, pulse ox, again, these patients will usually present in an acute crisis. The vaso-occlusive crisis, I have this delineated here for you, so take a look at it. But we also can have complications of intravascular as well as extravascular hemolysis, so we might have both related to the vaso-occlusive. The things that you need to consider here: if a patient presents with a low reticulocyte count in a vaso-occlusive crisis, if there is low retics, you should highly suspect a parovirus infection. And that can be very problematic for patients with sickle cell. All right, a quick look at the G6PD, and remember that this was looking at the this would be at the metabolic process of the red blood cells. So this is that glucose 6-phosphate dehydrogenase. It is X-linked recessive as well, results in a half-life reduction, and basically makes the cell susceptible to oxidative stress, particular hydrogen peroxide, normally neutralized by glutathione. This byproduct is NADPH, has a really long name, don't worry about it, but just understand it's NADPH. which is needed to actually regenerate glutathione. And since we cannot have that product, then we have in less glutathione, take 2 GCPD. Okay, GCPD, which is glucose 6 phosphate dehydrogenase deficiency. Remember when we talked about intrinsic versus extrinsic? So this is going to be an intrinsic defect. This is related to the metabolic process of the red blood cell. So normally we have glutathione, which is going to neutralize hydrogen peroxide. Remember we talked about oxidative stress. So what happens in this is there's a reduced half-life of G6PD, which renders the cell susceptible to oxidative stress. And we have NADPH, which is a byproduct that is usually needed to regenerate glutathione. What happens then is it doesn't regenerate the GLUT, and we have increased injury to the cell, intravascular hemolysis. This again is related to some Mediterranean African variants. There's a high carrier frequency related to malarial protection. So remember we talked about a lot of those variants are related to endemic malaria areas. And then here is just that pathway. Another one we're going to look at is paroxysmal nocturnal hemoglobinuria. So it's an acquired defect of the stem cell, which renders the cell susceptible to complement destruction. So here we have that complement system. It results in intravascular hemolysis, and it occurs sporadically at night. And the patho is that with the slower breathing, we develop a mild respiratory acidosis. It activates complement. We then get lysis of our blood cells, and we get resultant intravascular hemolysis, which leads to the hemoglobinuria and hemoglobinemia. And we would have evidence of it, especially in the morning, because this is happening at night. And then we would get the hemosideruria, again, refer back to the intravascular hemolysis process, and we would get that a couple days later. If the patient would have complications, it would be thrombosis of hepatic, portal, or cerebral veins because it is attacking all 3 lineages. Also, we would have iron deficiency anemia because that iron is being lost in the urine. And another thing may be acute myeloid leukemia as a complication of this. Aplastic anemia, so this is damage to the hematopoietic stem cell. Again, we're looking at that lineage. And it is going to result in pancytopenia, so all 3 lineages are going to be altered. We would then have a problem with the bone marrow production, so we would have a low reticulocyte count. This can be caused by many, many things. I do have a slide coming up that states all the etiologies. Just understanding some of the main causes, such as drugs, chemicals, infections, autoimmune. You must treat the offending cause, remove it, and then potentially the aplastic anemia would resolve. You would be supportive here by giving bone marrow stimulating factors, EPO for red blood cells, granulocyte macrophage colony stimulating factor, and then granulocyte colony stimulating factor. So you have to get those growth factors in there. Clinical presentation would be all 3 lines, so recurrent infections, fatigue, pallor, easy bruising, bleeding, tachypnea, dyspnea. Diagnostic workup, CBC with DIF, you're going to have the pancytopenia, reticulocyte is going to be low. You would need a bone marrow biopsy. You would also check your serum B12 folate levels. HIV testing, looking for etiology, LFTs to see if there is problems with the liver. If there's abnormal LFTs, it would be suggestive of maybe an inherited syndrome or maybe a recent hepatitis or exposure to toxins. So that would help with your differential. So here is the etiologies. It can be idiopathic, acquired stem cell defense, immune mediated. Here are the chemical agents. Physical agents, here are your immune issue or your infectious agents, Epstein-Barr, cytomegalovirus. So you see, those are the common players when we talk about a lot of our etiologies with disease processes and infectious agents. So CMV, EBV, herpes. All right. Are the other RBC disorders I just want to mention is polycythemia and polycythemia vera. So polycythemia is an abnormal elevation of the H and H. So this is directly related to the red blood cell system. There are your norms. And we have two classifications related to polycythemia, relative or absolute. And then absolute is broken down into primary or secondary. Relative has a lot to do with what? So this would be related to your blood volume, right? Because H and H is directly related to blood volume. So this would be basically related to hemoconcentration. Absolute is an increase related to the red blood cell mass and has multiple causes, and it will either be primary or secondary. Primary, we're looking at an acquired or inherited defect. So acquired or inherited defect of the RBC mass. Secondary, this may be related to EPO issues, so erythropoietin, and related to some other cause as causing the polycythemia. The relative hemoconcentration, because the concentration of the various RBC components in the peripheral blood, if there is a reduction in plasma volume alone, even in the absence of an increase in RBC mass, it will cause a relative polycythemia. Those main issues are related to diuretics, vomiting, diarrhea. Here is a nice little schematic. So there is that relative versus true polycythemia. And then we do pull a JAK2 lab, and JAK2 is the gene that is associated with the polycythemia vera. If it's negative, then you're looking at still maybe reactive, or is there an elevated erythropoietin? Because that's going to then help you. Is there potential issues with the O2? Is there hypoxia? Is there maybe an erythropoietin secreting tumor? And then maybe a congenital issue, and that also smoking, positive family history, early onset would lead you to help with that. If it's JAK2 positive, then you're going to have a diagnosis of polycythemia vera, which we'll move into next. Polycythemia vera is a neoplastic proliferation of mature myeloid cells, especially red blood cells. You may also see granulocytes and platelets increased. It is a JAK2 kinase mutation. The patho is mutations in the bone marrow by JAK2 result in erythropoietin receptor signaling issues, causing expansion of all three lineages, causing a plethoric symptom related to hyperviscosity. Your symptoms are all related to hyperviscosity, such as blurry vision, headaches, increased risk of thrombosis in the hepatic portal cerebral, your plethora, itching, all of that's related to that hyperviscosity. Your differential for polycythemia, again, refer back to this. You're really looking at JAK2 positive or negative, or a relative polycythemia as your differential. Diagnostic workup would be a CBC with diff. Your H&H would be elevated. Your white blood cells and platelets may also be affected depending on what's going on with the lineage. LFTs and your JAK2 gene would all be important. Your LFTs, your CBC, all that, or your CMP, LFTs, your kidney function would help also with whether there's volume contraction versus a underlying primary polycythemia. Okay, that is it for the red blood cell hematology lecture.